Greetings and welcome to Lobes and Robes, How Neuroscience Can Change the World. This podcast is sponsored by the American University Center for Neuroscience and Behavior and explores the links between neuroscience and key policy questions today. I'm Susan Carl, a professor of law at American University Washington College of Law, and I will help lead discussions throughout our series along with Dr. Terry Davidson, Director of the Center for Neuroscience and Behavior at American University and a distinguished professor of neuroscience here. This podcast is for anyone interested in how scientific discovery can make the world a better place. Thanks for listening.
As almost everyone knows, Alzheimer's disease and similar late-life dementias pose serious threats to human health and well-being. These cognitive disorders can be devastating, not only for patients, but also for the family members and friends that care for them. The global incidence of dementia has been projected to increase nearly threefold by 2050, making urgent the need for increased understanding of these diseases and for development of effective treatments. Furthermore, pathophysiologies that give rise to Alzheimer's disease and other dementias have been increasingly viewed as originating earlier in life. Thus, steps that younger people can take to prevent serious cognitive decline in late adulthood have also become a focus of both basic and clinical research. To discuss these disorders, we are very fortunate to have Dr. Gayatri Devi, MD, as our guest on this episode of Lobes and Robes. Dr. Devi is a nationally recognized neurologist whose research and clinical practice has focused on memory and cognitive dysfunction for over 2 decades. She is a multi-board certified in neurology, psychiatry, behavioral neurology, and pain medicine. Dr. Devi also holds clinical professorships in neurology and psychiatry at the Zucker School of Medicine at Hofstra University, Northwell. She is an attending physician in neurology and psychiatry at Lenox Hill Hospital, Northwell, and the director of Park Avenue Neurology, both in New York City. Dr. Devi is also the author of an influential book, A Spectrum of Hope, an optimistic and new approach to Alzheimer's disease and other dementias, and her published works of over 50 papers include recent articles in Frontiers of Aging Neuroscience, which describes the use of a precision medicine approach to deal with the complexities of Alzheimer's disease, and a paper in the Journal of American Geriatric Society on the tolerability and safety of aducanumab, also known as Aduhelm, which is recently approved drug for the treatment of Alzheimer's disease. Dr. Devi has shared her knowledge during appearances on 60 Minutes, Good Morning America, Today Show, CBS Morning News, and many other media outlets. We are extremely pleased and honored that Dr. Devi accepted our invitation to join us on Lobes and Robes today. Dr. Devi, welcome to our podcast.
Thank you for having me, Terry and Susan. It's a pleasure to be here with you.
So maybe we could start, if you could just talk a little bit about the research questions that are intriguing you these days and what led you to those particular research tracks.
The thing that's most interesting to me these days has been what exactly is the role of inflammation, which causes so many diseases of the heart, diseases of your gut, but also what does inflammation do with the brain? How does inflammation predispose us to developing Alzheimer's and other types of dementias? And what are things that we can do to ameliorate this? How can we prevent or reduce inflammation in the brain? So that's really my current focus. The other area that's intrigued me for many years now is this question of individual resilience. What is it about you and me that would make you more protected from brain disease and me much more susceptible? Individual resilience, if you will. So I think the idea is to support resilience, and how do you do that effectively on an individual basis? And so we do use a lot of lifestyle modification in our patients to do that, in addition to far more specific measures to address the dementia specifically.
So do you think the lifestyle changes, what do you think the importance of genetics? I know that there are particular genes that seem to be associated with it. Can you overcome those with lifestyle changes?
So I think many people believe that genes are the sole determinant of whether or not you're going to develop dementia. And I'm here to say that that's not true. I think genes play a role, but it's one of many factors contributing to whether or not you're going to develop dementia. And there are many facts that support this contention. First of all, most people who develop dementia develop it later in life, and late life dementia is almost always sporadic. In other words, not familial or not inherited. And most even early onset cases are often, that means people who get it earlier in life, earlier age, younger age dementia. Patients also don't have a family history. And there's a kind of puzzlement. How come I got this? No one in my family had this. Why did I get it? It's important to realize that even in identical twins, there's just about a 50% concordance rate for developing Alzheimer's. So, for example, identical twins, exactly the same genetics, but half the twins, there's only a 50% possibility that the other twin will get the disease. Although it's possible that if you waited long enough, the other twin will eventually get it. But the fact remains that there's a very, very different penetrance of something like Alzheimer's. And that's important to keep in mind.
That's a relief, I think. Yeah. For people who have it in the family, it's a relief to know that it's not a sure thing.
That's correct. Yeah.
You've identified, or I should say you've emphasized lifestyle factors. Have you been able to identify which type of lifestyle or environmental factors increase risk the most?
Sure. So about half, 50 to 60% of late onset Alzheimer's and other dementias can be prevented by embracing lifestyle factors. And these include very simple things, not to drink excessively. So you want to limit your alcohol intake to under 2 glasses or less of a wine type or another drink. You want to reduce your cardiovascular risks. If you have high blood pressure, make sure it's treated. If you have high cholesterol, make sure it's treated and well controlled. If you're obese, then that's something you want to control because that also affects your mobility and your physical movements. And that can also, lack of physical activity increases your risk for Alzheimer's. If you have hearing loss or visual loss, then again, you want to treat those because just taking care of hearing and visual loss reduces risk for dementia by about 7%. Try as much as possible to stimulate yourself cognitively, whether it's by talking to people, whether it's by going to a museum, and also, of course, and this is much easier said than done, to reduce the risk for social isolation. I think our society is increasingly going toward a place of loneliness for many of us, even as the world gets more crowded. And combating this kind of isolation, particularly as we get older, is important, I think, in terms of maintaining cognitive function and preventing dementia.
So those are all things that anybody can do. I'm wondering, in terms of the inflammation, are there indicators of what causes that, or is it an allergy kind of situation, or anything to do in terms of preventative approaches to that?
So neuroinflammation is a particular kind of inflammation where you have increased levels of free radicals in the brain, where you have higher levels of insulin resistance in the brain. So many of these factors, the easiest way I help patients understand it is by talking to them about cardiovascular risk. Anything that increases your risk for heart disease, which includes poor diet, which means a diet that's high in carbohydrates and refined carbs and high in fats, a diet that predisposes you to heart disease, will also increase the risk for insulin resistance, increase the risk for neuroinflammation in the brain. Other kinds of infections, sometimes viral illnesses, may somehow alter our brain's neuroinflammatory profile. And additionally, what other diseases do we have concomitant with the dementia? Do we have some level of lupus? Do we have multiple sclerosis? Do we have Crohn's disease? Do we have osteoarthritis, which many of us have as older people? Does that also affect our brain's ability to withstand the vicissitudes of something like the pathology associated with Alzheimer's?
Let me ask another question, and that is, what about brain trauma or concussions or those types of things in terms of the etiology of late life dementia? And particularly when these things happen earlier in life, what do you think the risk is related to those types of things?
Sure. I mean, I try to save that for later because a lot of times it's hard for us to prevent head injury. And then once people have some kind of significant head injury and they start worrying about Alzheimer's or dementia, it becomes problematic. But I do think repeated head injury obviously puts us at risk. When you're a child, you're playing a lot more soccer, you're more prone to head injury. We don't really know how that impacts later in life. The good news is the young brain is much more able to withstand any kind of insult or assault to it, as opposed to the older brain. So I think going into your 20s and 30s, et cetera, you want to be much more careful trying to protect your brain if you can. Although, as you say, our brain is protected. It's in a vault, the skull, a very hard calvarium. So the idea is you want to start thinking about brain health in your 20s and 30s, not in your 40s and 50s. You want to approach and begin to make lifestyle changes, et cetera, in your 20s and 30s and embrace those lifestyle changes that will promote brain health.
I think that's a message we can certainly underline it well also later in the podcast.
I find all of your approach so optimistic. It's really great to know that there are things one can do to be on the better side of the risk factors. I'm wondering, as we age, we all notice that we are having memory problems. Is that a normal part of aging, or is that a sign of cognitive decline in a way, Alzheimer's type way?
I think a good analogy is to our physical agility, right? So as we get older, we are going to slow down. We won't be able to stretch quite as, we are not as limber. We are not able to move quite as fast. As long as it doesn't affect our function, we're not thinking we have arthritis. We don't think we have joint or bone disease. But when it begins to affect our functioning, then we seek help and we see, well, what's going on? I think the same thing with forgetfulness. We're all going to start to forget in our 20s and 30s and 40s. It's going to be harder to remember names. It's going to be harder to learn new subjects. However, is that really interfering with our functioning? Are we continuing to do well in our area that we've chosen to work in? And if you're able to do that, if it does not interfere with functioning, then I would say it's not abnormal. But when it begins to, then it becomes an issue. And I think it's important for those of us who are in professions, we have a higher bar where there's more cognitive demand. And we may notice very subtle changes in our functioning. We're not quite doing well. It's taking us longer to do things. We're relying more on lists. We're having trouble multitasking. It's beginning to affect our functioning. We're getting stressed out. Then I think it's time to get a baseline evaluation to make sure there's nothing going on.
So when we talk about these evaluations, I know that not too long ago, the only definitive diagnosis for Alzheimer's disease required post-mortem assessment of the brain. What, if anything, has changed more recently?
This is the age of Alzheimer's biomarkers. So we now have blood-based tests that can evaluate tau and beta amyloid in the blood. These are the two pathological proteins that have traditionally been associated with the diagnosis of Alzheimer's disease. There are some other abnormal proteins that we can also look for in blood that's not quite as specific for a diagnosis of Alzheimer's because it can be found in other brain diseases as well, including concussions, for example. Then we have cerebrospinal fluid-based biomarkers, which are where you can do a spinal tap, remove some fluid, and analyze that. That's probably a little bit more accurate at this time compared to blood-based biomarkers, but the blood-based biomarkers are rapidly catching up. And then there are scans, brain scans that look at levels of tau and amyloid in the brain. Much more expensive. Tau scans are still not commercially available. that also do the same thing, evaluate for biomarkers. And with these biomarkers, in the presence of certain patterns of cognitive impairment, you can pretty much make a diagnosis of Alzheimer's with a high degree of certainty without an autopsy.
Yeah, that's a change. There were things I've noticed recently, and there seems to be a lot of things that appear in the press. One thing had to do with people's gait, another was voice intonation, and as predictors of AD and AD-like dementias. Now, again, predictors, not necessarily diagnoses of those disorders. I was wondering what you thought about some of these diagnostic tools.
What I've learned in my practice is that people are more scared of developing Alzheimer's and dementias than they are of developing cancer. It's our greatest fear that our bodies are going to outlive our brains, and we're going to be just bodies without any ability to direct ourselves, without any control over ourselves. So these kinds of studies, while they're important, you want to take with many grains of salt, because as we get older, we are going to be slower. As we get older, we are going to walk a little bit more stooped. As we get older, our voices are going to lose some of the cadence and some of the strength. So while it's important to help in a scientific way, I think when the lay public hears about this, it causes unnecessary alarm. I've had so many people come in to say, I've lost my sense of smell. I can't smell quite as well. Do you think I have Alzheimer's disease? That kind of thing. What I think may be helpful is if you do notice that you're getting slower in your walking, then maybe more physical exercise, because it's well known that we lose about 50% of our muscle mass from the time we're in our 20s to the time we're in our 60s and 70s, unless we do something to combat it. So sarcopenia and muscle mass loss is rampant as we get older, and that causes weakness and changes in our gait.
I'm wondering, do you think that Alzheimer's disease is underdiagnosed, overdiagnosed? What's your sense of that?
I think it's very, very underdiagnosed. I saw a patient yesterday in my office who couldn't tell me the names of his children. He's a man actually not that old, 78 years old. Couldn't tell me the names of his children. Didn't know what country he was in. He's American. He's born and grew up in the United States. Didn't know, obviously, what the date was, but he didn't even know his own age. And he had been followed for 9 years by another neurologist who I adore and is a fantastic neurologist, but not a cognitive neurologist. So this man had a diagnosis of mild memory loss, had not been put on any medication. And I think the reason is, it's not because the other neurologist didn't see that he was getting progressively worse. Two main reasons. One, that both physicians and patients are afraid of the A word. We're afraid of using the Alzheimer's word or the D word, dementia, because both physicians and patients feel that nothing can be done about it. And neither group, and again, I'm making vast generalizations and I apologize for this, but I would say the majority of physicians and patients and the population at large feel that very little can be done about it. So why bother? Why have this difficult conversation if we can't really do very much about it, much as our conversations around death and dying and aging? Because death and dying, we physicians rarely like having those conversations also.
So I think your approach also kind of addresses these problems you're mentioning, in that you indicate, and I think this departs from popular views, that people diagnosed with AD are often very capable of performing even complex jobs. And I think that's also something that is hopeful. And you also talked about in your book, of course, that there's a spectrum of dementia. Can you maybe tell us a little more about that?
I actually wrote about this in the New England Journal, where I talk about this physician who was a woman in her early 80s, brilliant, scored at the 99th percentile on her cognitive tests, but her memory was quite impaired. She'd been diagnosed with Alzheimer's at an Alzheimer's disease research center in the city and told that she needed to stop working immediately. She had two jobs, one where she taught at a university center and the other taking care of a very small group of patients. She was very highly specialized, and many of these patients had been with her for 20 to 30 years. The interesting thing was she had just been given Teacher of the Year award the previous year. She was amazing. She's an amazing teacher because a lot of her teaching had to do with things that it was hard for her to forget, that almost become part of the fabric of her brain. And she was an excellent teacher. The qualities of being a teacher, listening, being able to care about your students, all those qualities she still had. So she gave that up. She also was told to give up her practice, and she was very reluctant to do that because she needed to make sure her patients had found the right follow-up physician so that she wouldn't just abandon them. So I got to see her as part of what's called a physician's protection program, essentially, that each state has. And during my evaluation, I noticed that, yes, she has some memory problems, but she's been able to compensate for it, and she's cared for her patients very, very well. So we put a monitor in place, and she was able to take care of her patients for several years, and then retired in her own good time, feeling very proud that she had made sure that her patients were taken care of. So generally speaking, I feel that a diagnosis of Alzheimer's can be stigmatizing in a way that a diagnosis of alcoholism or drug abuse or stroke is not, even though any of these conditions can also cause significant cognitive impairment, sometimes way more cognitive impairment than Alzheimer's does. I think that's another reason that people avoid giving the diagnosis to patients. Physicians avoid it because it could mean that the patient is then stigmatized. And I feel that patients with Alzheimer's can continue to be very, very capable. And my threshold always is to say, well, would I go see this lawyer with Alzheimer's? Would I be the passenger in this car with this grandmother who has Alzheimer's? Would I have my daughter have her child be delivered by this obstetrician with Alzheimer's? And if the answer is yes, and it often and surprisingly often is a yes, then I say, you're capable of continuing to function. And many times in patients with severe depression, say, or a patient who's had strokes, or a patient who's being treated for chemotherapy, the answer is no. No, this person is not currently capable. And we don't do that.
I think one of the reasons people hesitate to get diagnosed is they think there's no good treatment. There's nothing to be done about it. Is that still true? Or are you finding that there are some treatments that are effective for more than just a couple months or something?
That's correct. I feel that even the drugs that have been given, the Ariceps, the donepezil, which people used to say was only effective for about 6 months, they've subsequently done studies that have shown that patients who have been on these drugs, these cholinesterase inhibitors, just being on those drugs delayed placement to nursing homes by as much as 6 years, which is a substantive number. So my approach is, we still don't exactly know what causes the loss of the cell connections, nerve cell connections, or the synaptic connections in patients with Alzheimer's. Is it the inflammation? Is it the tau? Is it the amyloid? Is it some other unknown factor? Is it a combination of those things? And so my goal in treatment is targeting what we can target, known targets. So you want to be able to increase the level of acetylcholine in the brain. You want to improve the neural circuitry in the brain. You want to promote the resilience of the brain by reducing neuroinflammation. So I really believe a cocktail approach, approaching this condition from multiple directions, much as what we've done with HIV, for example. It's still not curable, but I now have patients who have HIV for 30, 40 years, and they've been stable for this time for 30 some odd years from the 80s onwards because they've been on a cocktail approach. They've been on multiple medications that slows progression and keeps the illness at bay. So I think it can very well be treated.
It's interesting that when we're talking about, you mentioned inflammation before, and we're looking at causes for cognitive function in AD, amyloid protein plaques and tau tangles were considered main cause for a long time. And now you're indicating there's other pathologies. One of the implications, I think, for that is the notion of the new FDA-approved drugs, the aducanumab, for example, or Aduhelm. This has generated a lot of interest and hope, and they work by, I don't want to say dissolving, but reducing these amyloid plaques. Are they going up the right avenue there, or are these drugs effective? What is your opinion on this form of treatment and the whole notion that these protein plaques and tangles are the main cause of the disorder?
So what's interesting is that if you look at genetics, going back to genetics, every single mutation of a gene that increases your level of amyloid is associated with an increased risk for Alzheimer's. Every single gene mutation, whether it's on chromosome 21, chromosome 19, chromosome 14, or chromosome 1. That's a huge factoid that we cannot dismiss when we're looking at the etiology of Alzheimer's. Now, and the other caveat to that is that there is no mutation of the tau gene, and there are many mutations of the tau gene, that is associated with an increased risk for Alzheimer's disease. There's no single mutation. So that also is important to realize. So putting these two together, what can I say? I can say, well, amyloid is definitely implicated. Tau is also implicated because just amyloid alone doesn't give you the clinical picture of Alzheimer's. And if you have these drugs that go after amyloid, and especially if you introduce these drugs early on, because the data is now overwhelming that the amyloid pathology begins at least about a decade before the tau pathology begins. So in other words, something about the progressive accumulation of amyloid triggers tau accumulation, then maybe you can basically alter the course of the condition. Maybe you can even prevent completely ever getting Alzheimer's if you start on the drug early enough before you even have clinical symptoms. With that in mind, we have had a couple of patients in my practice who have a very, very strong family history of Alzheimer's, who don't yet have clinical symptoms in their late 40s, early 50s, who chose to go on these anti-amyloid medications. And over 2 years, they are now plaque-free. They no longer have plaque. And the question is, will they develop tangles down the road now that they no longer have plaque? So that's one group, the very early intervention group, where I think these monoclonal antibodies against amyloid will have the biggest impact. Then there's the other group with very early onset Alzheimer's, where the Alzheimer's is still very early and it's early in its stage. What can you do there? Infusion with monoclonal antibodies, it's an intravenous infusion once a month or once every 2 weeks, has also in many patients stopped, reduced, and dissolved the plaque entirely in the brain. And interestingly, in almost all the cases, there's also been downstream reduction in tau. So many of these patients have about a 10 to 15% reduction in their tau protein as well. So somehow there seems to be some connection between the tau and the amyloid, and precisely how this happens, we don't know. And it seems as though the monoclonal antibodies, even though they're targeting primarily the plaque, seem to have some effect on tau.
So the question, and I think I've seen you address this in one of your papers, improvement of cognitive functioning in people diagnosed with AD. Are these drugs producing that? Or is there good evidence for, is the jury still out?
In all these situations, what I always tell patients is we're not aiming for improvement. Our goal is slowing progression. And I always tell them there's no cure. So we do have cases, though, where patients have stabilized on the monoclonal antibodies and some have even improved. So, for example, I have a 74-year-old woman who was diagnosed with significant Alzheimer's. And the first time in 2021, when she had her spinal tap, which I did in the office, she had to be driven in by her husband for the tap. And then she got picked up because she lived in Westchester, which is a suburb of New York. And then she received monoclonal treatment for 2 years, in addition to some other treatments, including brain stimulation and to be on these other medications. And I said, well, it's time for us to repeat the spinal tap. The second time around, 2 years later, she drove in by herself got the tap, and drove back. It may not seem like a lot, but it's in terms of two things, basically her level of function, but also very importantly, her level of confidence in her own competence had increased. But concomitantly on testing, she had improved in function.
Susan, I have just one more question to follow up, and I'm sorry I'm kind of dominating here on this topic, but one of the things that I was wondering about is there are a number of folks, at least some studies out there that suggest that you can have people that have substantial amount of the protein plaques and also tau tangles without having deviating from their normal memory function for their age. And you were talking about resilience before. Are these folks, how should I say, resilient or resistant to the effects of the tangles and plaques somehow?
Yes, that's I'm glad you brought that question up again, because it's an area that really interests me. This question of what is it? What is it in the brain that makes some people completely impervious? It's almost like they're wearing cognitive raincoats and the plaques and tangles just fall off of them. And what is it about them? I was talking to a patient the other day. She's 78 years old. She has Alzheimer's, but she told me she's never had a cavity in her life. Born in New York City, raised in New York City. Now, less than 1% of adults will never have cavities in their lives or some evidence of tooth decay. Her children don't have any cavities, and they all grew up on diets which were high in sweets, etc. So there's something about her that protects her from tooth decay, despite all the sweets and everything she eats, a regular American diet. So what is it about some patients, the so-called super agers, who are riddled with plaques and tangles and yet never show clinical symptoms of Alzheimer's? Now, it's possible, or other dementias, if they live long enough, they will, but they live into their 90s and they don't have it. And I think there are two reasons for it. One is the brain as a supercomputer has multiple routes to achieve the same function. So even though we have a dedicated part of the brain that deals with language, if we have a stroke that kills off that region, other areas of the brain step in and take over that function. So is it possible that in these super agers, their parallel distributed processors, their multiple processors are just much more capable? Are they growing synapses at a faster rate so that as the synapses get clipped off by these pathological substances, they're just sprouting them more? Do they have some kind of neurotrophic factor that we have not yet identified? Or is their brain just more resilient to begin with? We know that people who are more educated or people who are more cognitively rich, if you will, coming into the illness, seem to maintain function longer despite the pathology progressing. But what else is there? So that's really very interesting.
Yes, I agree. It is interesting. It'd be nice to be able to find that out, especially if there's ways to increase resilience in folks who may not have it.
Yeah.
I heard you mention that one of the ways you treat patients is with brain stimulation. And I'm wondering, is that a promising route for slowing progression?
Neuromodulation, which is to modulate brain activity using external devices, is a very exciting field in neurology. And the area that I've done research in since 2008 is the use of transcranial magnetic stimulation, which is the passage of magnetic current through the skull, which then creates a small electrical circuit in the area of the brain under that coil, which is about 1 centimeter square, very, very small area, that then creates activity in the neural circuit and then increases the synaptic density of that circuit, that can maintain resilience. The questions are exactly what parameters should be used to stimulate? What parts of the brain are optimally stimulated? How do we get to the deeper brain regions, such as the hippocampus, the heart of the kind of declarative memory that we need to function, which often is hard to access from the surface of the brain? These are the areas that we're working on, but the data, in my opinion, strongly supportive of the use of neuromodulatory techniques to increase the brain's resilience, mainly by bypassing the cause. Doesn't matter whether it's from you have brain dysfunction from a stroke or from drug use or from dementia, such as Alzheimer's. You can just increase the synaptic density in these circuits, increase the activity in those circuits that are failing. And by that method, improve brain resilience and improve functionality in a patient.
That sounds very, very exciting and promising. Terry, any thoughts on that since you know about the brain?
Yeah. I studied hippocampus, and it's not easy to reach with brain stimulation. But I will say that what resonates with me about this, so in animal models, rodents, they don't develop plaques and tangles, but they do get inflammation, and they will show deficits in memory functions that depend upon the hippocampus. I do think if treatments could be targeted at that brain area, it may have some positive impact. I guess we mentioned this earlier in the podcast, but I'd like you to maybe reemphasize, and that is what can be done early in life to prevent the onset of dementia in late life. I think that's probably the main question in terms of prevention. And I guess we shouldn't forget people in late adulthood who are worried about it. You've already mentioned some of this stuff, but what can they do to prevent dementia?
I think the single most important thing that we can do to prevent dementia and to just promote brain health in general is to prioritize sleep. That's increasingly hard for us to do in society because we just are called upon to do more and more. And sleep seems to be the part of time that we just automatically go to and get more out of. But in the process, I think that we've created an epidemic of increased anxiety, reduced attention, and increased cognitive disorders, including possibly Alzheimer's. And the reason is because sleep, which is conserved across species, birds do it and bees do it. They all sleep, and we sleep too. The reason is that during sleep, there is a resetting of the neural circuitry. The brain's lymphatic system, which is a sanitation system in the brain, removes toxic substances from the brain. The brain consolidates memories that you've learned during the day. It replays those memories. Zebra finches replay songs to make sure that the songs sound exactly like they want them to for the next day's singing. Sleep is very, very important for us. And sleep is also a time when we can reduce risk factors for anxiety and depression, which are also risk factors for cognitive disorders down the road. So sleep, I think, is the single most important thing that we can do to sleep well and long and for as much as we can every single day. We were experts when we were babies. We lose it as we get into our teenage years because everyone wants to get into a good school. We're overscheduled. And all this scheduling, I think it's wreaked havoc on sleep. And then you get into a bad habit in your 20s and your 30s. You start to prioritize everything but sleep, the fear of missing out, etc. You medicate yourself during the day with caffeine and Red Bull and espressos and stimulants. So many young adults are on stimulant medication. And then at night, to power yourself off, you go on sleep medication, which are also associated with increased risk for dementia. So sleep, I think, is the single best preventive thing you can do. Beginning in your late teens, you get into the habit of prioritizing sleep. Sleep is not this inexhaustible place to remove time from to apply to other areas. So that's number one. Obviously, to eat well, eat a diet that's very low in carbohydrates, especially the refined carbs that are so pervasive in our diet. And those refined carbs and this kind of same genetically modified diet also changes our gut biome, which we didn't really talk about, but that's one of the big sources of inflammatory agents. And also it can be very helpful in ameliorating runaway inflammation sometimes when it's properly constituted. So diet's important. Physical activity, we tend to be very sedentary creatures, prone to being hunched over our computers or our cell phones. So that's important to do something much more physical, to be more part of the organic world that our brain is used to. Walk, talk to people, get away from your iPhones. Social isolation, which, as we say, as the Surgeon General recently mentioned, is an epidemic, the loneliness, particularly in older adults, but even in young people, loneliness is rampant. Those are, I think, important things: diet, sleep, activity, and people, other people, social relations.
You mentioned that diet was a major factor and also social isolation and our obesity rates, which seem to be linked to processed foods, high in carbohydrates, high in saturated fats, as well as folks being involved in their iPhones and social media without necessarily interacting with people. That's on the rise as well. Does that necessarily portend for, I should say, major problems or increased incidence in the future?
Oh, yes, absolutely. I mean, obesity is an international epidemic right now, particularly in developing countries, because people now have easy access to the most addictive substance known to mankind, which is sugar. It's not crack, it's sugar.
Absolutely.
And sugar is institutionalized. Drug corporations, in my opinion, that sell and peddle sugar are as criminal to me, in terms of the kind of devastating long-term impact they have on the health of populations at large. Companies like Pepsi-Cola, companies like Nestle, because they're peddling sugar, which people crave and become addicted to. And what does obesity do? It causes type 1 diabetes in young children. It's causing, type 2 diabetes, increasing the risk for heart disease, increasing the risk for joint disease, high blood pressure, cholesterol. And every single one of these conditions increases your risk for brain disease and Alzheimer's.
Not to mention inflammation. Yeah.
Yeah, absolutely. I mean, it's tragic that we are peddling. There's a war against drugs, but the war against the biggest drug of all, which is sugar, no one's talking about.
That's such a good point. And we've had some other people on this season who've been talking about diet and its connections with the brain. So I wish we could talk to you for a lot longer. It's just wonderful to be able to tap into all of your expertise and your optimistic outlook. We're going to have to close soon, but maybe we could close just with your describing to us what you see as the future of the kind of research you're doing and the increase in knowledge about Alzheimer's and dementia.
I think the future with Alzheimer's and dementia is going to be a very tailored precision medicine where each individual brain and each individual person is analyzed, looked at in every way, from the perspective of neuroinflammation, from the perspective of the heart, from the perspective of their joints, their bones, and how that impacts on their brain, from the perspective of the composition of their gut biome, how that impacts on their brain. And then a very granular look at their brain itself to see what other diseases coexist with their main diagnosis, whether it's Alzheimer's or vascular dementia or some other type of cognitive impairment. How their synapses, what are their strongest areas of connection, this type of granular approach. What genetic risks do they have that confers more difficulties ahead, and what genetic benefits do they have? What areas that might be beneficial? What genes do they have that are beneficial that may ameliorate those risks? These are the things, very kind of focused approach that's specific to each patient. That's the only way we can really be truly successful in keeping each of us functional for as long as possible.
So, Dr. Devi, I want to thank you so much for joining us today. This has been a fantastic podcast, so informative, and how should I say, dealing with topics that are certainly relevant now, and how should I say, of a concern to many, many people. And I think you've enlightened us in a lot of ways, and also maybe dispelled some myths that we've had. And that's what you're known for doing, by the way, dispelling myths about these diseases. And I think you certainly did that today. So I'm so happy you joined us today, and I thank you very much.
Well, thank you very much, Susan and Terry, for having me on your podcast. I very much am honored to be here. Thank you.
Well, that's it for this podcast episode. Thanks very much for listening. And as always, we welcome your feedback at neuroscience.policy@american.edu. We hope you'll join us again for our next episode. And do let us know if there's anything in particular you'd like to hear more about.